Okay, so here we'll talk about the oropharyngeal abscesses. Now you might hear oropharyngeal and think, what does that have to do with pulmonology? And the answer is really not a whole lot, but I didn't really know where I could put these in. And there are some implications for pulmonology in as much as the complications do involve the lungs. We're going to see that with any of these neck abscesses, if they erode the trachea, you can get aspiration pneumonia. Also, the fact just that this exists around the trachea, and I figured we could put it in here. So we're kind of squeezing it in. But nevertheless, regardless of what heading you want to put over this, this is a pertinent topic for the USMLE. Okay, so we'll do a quick overview, and then we'll talk about the relevant anatomy. That's going to be really important, not only for diagnosing this and differentiating them from one another, but also for understanding where these spaces are and what other structures are in that area. We'll talk about the retropharyngeal abscess, the lateral pharyngeal abscess, which is also called the parapharyngeal abscess, and then we'll also talk about the peritonsillar cellulitis or abscess, and then we'll do some quick notes, and I'll also bring up something called Lemierre syndrome, which is typically a complication of lateral pharyngeal abscess or peritonsillar abscess. Okay, so in the neck, in the cervical spaces, you have a couple discrete spaces. They do communicate with one another, so some of these boundaries are artificial. But the retropharyngeal space is located between the pharynx and cervical vertebrae, extending to the superior mediastinum. So basically what you have here is your pharynx and then the esophagus. Whatever's behind that and in front of the cervical vertebrae, that's your retropharyngeal space. And this communicates with the lateral pharyngeal space, which has various definitions, but for the most part it's bounded by the pharynx medially and the esophagus medially, then the carotid sheath posteriorly, and the muscles of the styloid process laterally. So that's a rough definition. Other definitions I've seen will tell you that the superior border is going to be the base of the skull, roughly the sphenoid and temporal bone, with the medial border, again, being the pharynx, the posterior border, again, being the carotid sheath, and then the lateral border, I've heard it described as the digastric muscles, styloid muscles, medial pterygoid muscles, parotid gland, the ramus of the mandible, but roughly you're getting the same area as described here. And like I said, keep in mind that the retropharyngeal space does communicate with the lateral pharyngeal space. Okay, so the nodes in the deep neck space intercommunicate, of course, like they're lymph nodes, right? And they drain the nasopharynx, the adenoids, and the posterior paranasal sinuses. There are a set of nodes that exist directly behind the pharynx, and these are called retropharyngeal nodes, based on where they're at. And they involute at about 5 years of age. And so this is going to have some importance when we talk about retropharyngeal abscesses. Deep neck abscesses usually occur as a result of lymph node infection. And where do you get a lymph node infection from? Well, you get it from an infection from somewhere else, and the lymph nodes drain it. So usually this is going to occur in the setting of usually something like pharyngitis or some kind of infection of the pharynx or inside the mouth or possibly even of the esophagus. So the nodes, what happens is, you have your nodes that are designed to drain infection and cause white cell proliferation, but what can happen is they become infected. Then these nodes can be compromised. They'll go through stages called cellulitis, and then where they become a phlegmon, and then ultimately abscess. And when they abscess and they burst, they lose their integrity, that's going to cause an abscess within the particular space. You can also get these abscesses from penetrating trauma, from a dental infection, which then subsequently spreads, Also from acute otitis media, and then it can be caused iatrogenically, like say for instance you're doing an endoscopy and you penetrate the pharynx, that can do it. So there's various causes, but on the test, for the most part, I think they'll give you a history of an ENT infection, like pharyngitis. The pathogens are polymicrobial. You can imagine that there are a lot of things in the mouth and the pharynx that can be infectious if they get outside that area. The most common isolated pathogen is Strep pyogenes, the group A Streptococcus. You can also see Staph aureus and possibly MRSA, particularly if it's endemic to the community. And then, of course, your oropharyngeal anaerobes, which are omnipresent in your mouth and pharynx. And these anaerobes include such species as Bacteroides, Peptostreptococcus, and Fusiobacterium. The complications of any of these abscesses include airway compromise, since we're in the general vicinity of the trachea, posterior mediastinitis if it goes that far down, aspiration pneumonia. So here we would have to have an erosion of the pharynx or of the trachea if it's far enough down. And then what happens is that will then drip down into the lungs. So you're not really aspirating as much as you're just getting a passive drip from any kind of erosion to the airway. Thrombophlebitis can occur. When this occurs in the internal jugular vein, it's called Lemierre syndrome. We'll talk about that at the end. And then you can get erosion of the carotid sheath, which can cause all sorts of problems with anything that's in the carotid sheath, and then sepsis. Okay, so here you have your pharynx, you have the hyoid bone here, and then I kind of faded out the tracheal cartilages, and this is going to go down into the esophagus. So these, of course, are your cervical vertebrae, and so the space in between the cervical vertebrae and the pharynx and esophagus, this is going to be your retropharyngeal space. Okay, so it's kind of difficult to visualize this this two-dimensional representation. If you look at it this way, you're not going to be able to see the retropharyngeal space here because it's covered up by the esophagus and the pharynx, but it would be behind this structure, all these structures. So anteriorly bordered by the posterior wall of the pharynx and esophagus, and posteriorly bordered by the anterior part of the cervical vertebrae. Okay, so now we're going to look at the retropharyngeal space. So where are our landmarks? Here's your styloglossus muscle, which comes from the styloid process to the tongue, and then your stylohyoid muscle, which comes from the stylus to the styloid process to the hyoid bone, which I've dissected here, and then the digastric muscle, which also goes to the hyoid bone. Okay, so here's these muscles, and this makes up the lateral border of the parapharyngeal space. Okay, you also have your carotid sheath. Now this is posterior. All right, so two-dimensional. It's difficult to visualize this, but this is very much posterior to these muscles here, and also to the pharynx. Okay, so the carotid sheath includes what you can see here are your the carotid artery and the jugular vein, which then roughly at the level of the tracheal cartilage, of the thyroid cartilage, will split into internal and external. So at this level, you have both internal and external jugular veins and carotid arteries. This sheath also contains the deep cervical nodes, which you can't see here, but they're there. The vagus nerve is also there, and then you also, at various points, have cranial nerve 9, which is glossopharyngeal, cranial nerve 11, which is accessory, and cranial nerve 12. Okay, Abscess cervicalis, this is something that exists on the anterior part of the carotid sheath. You don't really need to be worried about that. So what you do want to consider here is that you've got these structures in the carotid sheath, and any of these can be compromised in the event that you have erosion into the sheath from an infection. So, for instance, you get erosion of the carotid artery. What can you get from that? You can get a hematoma. You can get bleeding. That would be really bad. Internal jugular vein, you can get thrombophlebitis. That's Lemierre syndrome. Deep cervical nodes, well, that's usually where the problem is coming from. Vagus nerve, you can get neurologic deficits from, and then you can also get neurologic deficits from 9, 11, and 12. Okay, so this is our region here. So bordered medially by the pharynx, bordered laterally by these muscles coming off the styloid process, and then bordered posteriorly by the carotid sheath. Again here, here's your landmarks, and this is the area we're talking about. All right, so enough of the anatomy. Retropharyngeal abscesses are the second most common neck infection in children. The most common is the peritonsillar abscess, which we're going to talk about a little bit later on. It occurs most commonly in children under 3 to 4 years of age, and there is a slight male predilection. So why does it occur more commonly in children under 3 to 4 years of age? The answer to that is because this comes from a destruction of the lymph nodes that exist behind the pharynx. Those are called retropharyngeal nodes, and they tend to involute around 5 years of age. So because adults don't have those nodes, we tend to not get this kind of infection. Now, adults can get this kind of infection if it comes from other causes, so penetrating trauma, iatrogenic, if you get pierced by an endoscope. It can certainly happen to adults as well, but it tends to not happen as a complication of ENT infection, which is the most common cause of any of these abscesses. So it is associated with a recent history of an ENT infection, so definitely keep an eye out for that as part of the patient's history. So they might not have the ENT infection at the time, they might not have pharyngitis visually if you look at their mouth and throat. However, a history suffices. So this would be something like strep pharyngitis. Symptoms include fever, irritability, stridor, muffled voice, decreased PO intake, drooling, neck stiffness, torticollis, refusal to move neck. What does this sound like? This sounds like epiglottitis, and that is a big differential. Now, usefully, we vaccinate people against Haemophilus influenza type B, and that means that epiglottitis is much less common. However, any patient who's not vaccinated or a patient who has immunodeficiency, you need to keep this in mind. Keep it in mind no matter what, but just remember that epiglottitis is just not that common in the US. So you can imagine why all of these are going to take place. You've got the fever because you have an infection, irritability because they're uncomfortable, stridor because there can be a certain level of resistance in the pharynx because you have a bulge from the abscess. Muffled voice occurs for a similar reason. Decreased PO intake, a lot of times it's painful for them to drink, and so they're going to drink less. Drooling, again, if you have enough compression of the pharynx from the abscess, then it's going to be difficult to swallow. That difficulty to swallow is going to then come out as drool. Neck stiffness, just from the infection, torticollis, if it's large enough, it can distort things, and then refusal to move neck because it's painful. They may also complain of sore throat and neck pain, especially if they're verbal, older children. Younger children, it's a little bit more difficult. And by younger, I mean not old enough to talk. It can be a little bit more difficult to elicit these symptoms because they have to be described. On physical exam, in many cases you'll note dehydration, especially if this has been going on for a long time, they haven't been drinking. But what you really should notice, and you'll tend to notice this in older children as opposed to infants and toddlers, is a bulging of the posterior pharyngeal wall. If you get a good look inside the mouth, you will probably note some bulging. But this only occurs in around 50% of patients. Usually going to be significantly less than 50% if they're very young, like 1 year old. And it'll be maybe a little more than that if the patient's 3 or 4 or 5 years old. You can also note tender cervical lymphadenopathy, and then in very severe cases, you can note respiratory distress. So what's our differential? Well, we already talked about epiglottitis. Remember that epiglottitis is less common. What to look for in the history. Look for either immunodeficient or they have no vaccination to Haemophilus influenza type B. Also, the very first step we're going to do looking for retropharyngeal abscess as far as radiology is concerned is going to be a plain film x-ray. So look for the thumb sign. The thumb sign will be present in epiglottitis. You just look for the epiglottitis, you'll see that it's big, and then you can diagnose epiglottitis. This will not be present in the retropharyngeal abscess. Foreign body obstruction, typically we can get this based out of the history, but regardless, there is no fever or symptom of infection in foreign body obstruction unless you're in the very, very late stages of foreign body obstruction where you're getting erosion. You can also note a sudden history of stridor, and then if you get an x-ray, it should be very apparent. In most cases, you'll have a foreign body visible in most cases. Meningitis is a very difficult differential here, especially if you have a very young child. So in this case, the voice should be normal. The PO intake is often better because they don't have any pain or obstruction in their esophagus or in their pharynx. You can get neck pain. It may be difficult to rule out in a very young child because so much of the meningitis issues surround explanation. But the fact that the voice is normal, PO intake is better, can be very helpful. But regardless of this fact, you're going to get an x-ray to help with your differential diagnosis, and the x-ray from meningitis will be normal. Lymphoma can be difficult as well, but with lymphoma, they typically don't have this myriad of symptoms. They shouldn't have a fever, but that can be complicated. But if they do have lymphadenopathy, it should be non-tender. And again, the x-ray will be normal. Retropharyngeal hematomas are typically going to come with a history of trauma, but they can result from a retropharyngeal abscess. Remember, if you get erosion into the carotid sheath, you can get bleeding into the retropharyngeal space, and into the lateral pharyngeal space for that matter. Vertebral osteomyelitis, you'll have a normal voice. This is just a localized infection of bone. You can possibly also have a fever. PO intake will be better, and then neck pain. The x-ray will be normal. Possibly an acute radiologist, astute radiologist might be able to pick up a osteomyelitis on x-ray, but the CT will for sure, to any trained eye, will be obvious for a infection in the vertebra. And this can cause a retropharyngeal abscess, and it can also result from a retropharyngeal abscess. So it's working two ways here. You can get a spread of the osteomyelitis into the retropharyngeal space. Likewise, an infection of the retropharyngeal space can come into the bone. Remember that the retropharyngeal space is right in contact with the vertebral bones. So for diagnosis, you'll probably start with a soft tissue cervical plain film. And the reason is that this will help you rule out, without going straight to CT, this will help you rule out some of those things on your differential. You want to get AP and lateral views, and when you get the lateral view, what you'll want to do is have the patient extend their neck. And that will help you sort of make it easier to visualize the entire retropharyngeal and parapharyngeal spaces. You want to look very carefully at the prevertebral strip, because that's where the retropharyngeal space is, for widening. And in a retropharyngeal abscess, widening is present. You can also note other signs and stigmata of abscess, which can include air fluid levels or air bubbles. A neck CT with contrast is more accurate, and if you suspect retropharyngeal abscess from the x-ray, you're going to do this. You're going to get a neck CT with contrast. And what you'll note is a ring enhancement and central lucency. Sometimes you can see some air bubbles, and the airway will be displaced anteriorly because of the infection. The space between the airway and the vertebrae is not very much. We're going to see when we look at CTs, you'll see that there's not much space. The retropharyngeal space is not very deep. So it'll be pretty obvious if there's an infection there. Next CT is very easy to determine widening. The management is, of course, you're going to start with your ABCs. You'll ensure a secure airway. In most cases, there's not respiratory distress. However, if there is, then this provides us with a problem. You need to remember that a direct laryngoscopy increases the risk of rupture. So if you try to go in there with a laryngoscope and you puncture the part of the pharynx that is holding the abscess back, then you can get all sorts of drainage of pus, which can then be aspirated, and you get aspiration pneumonia. So you have to note that a direct laryngoscopy increases the risk of rupture. If you do a fiber optic laryngoscopy, that tends to be preferred. However, it's not always possible in every facility. That would be better. If you can't do that, it may be preferable, instead of doing a direct laryngoscopy, to just do a tracheostomy, because at that point then you're totally bypassing the abscess. You'll want to provide IV fluids. Most of these patients are susceptible to dehydration. You'll get routine labs, CBC, BMP, you can get a SED rate, and then IV. Also, if the patient is febrile and toxic looking, you also want to get blood cultures. IV antibiotics should be commenced. It's really the cornerstone of treatment. You're going to do that for every patient that has retropharyngeal abscess, parapharyngeal abscess, or peritonsillar abscess. There are varying approaches to antibiotics. I'm going to show you that at the end of this lecture, how different sources recommend these regimens. So I took mine from Nelson's Textbook of Pediatrics, which I believe is a very reliable source. But for the most part, what you need to remember are the pathogens. The pathogens are Staph aureus, Strep pyogenes, and your oropharyngeal anaerobes. So you want to make sure that you're covering Staph, Strep, anaerobes. So this is going to be a pretty broad-based therapy. You'll use a third-generation cephalosporin, and then you'll cover anaerobes. And you should consider MRSA if it's prevalent in the community. So something like ceftriaxone, and then add on to that something that's got good anaerobe coverage, like ampicillin sulbactam or clindamycin. You can also use vancomycin if you're worried about MRSA. Pediatric ENT consult, of course, is going to be in order because a lot of these patients will require surgery. So you'll have these kids on watch for 24 hours, and if they don't improve with IV antibiotic therapy, then they're going to need surgery. And then whenever that surgery is done, you'll get a culture and sensitivity from that pus, and that will help you decide whether or not you need to change antibiotics. Oh, and I also will note that you're going to do immediate surgery if there's really bad complications like airway compromise and stuff like that. Okay, so here's a normal lateral cervical x-ray. What you can't see are your airway structures here very well. This is a soft tissue x-ray. You can see your vertebrae very obviously here. And then this is that soft stripe, which roughly corresponds with your retropharyngeal space. So note how it's very parallel to the anterior aspect of the bones here, and it's not very thick. Now you compare that to a retropharyngeal abscess. This is very obvious here. So you have a very, very much expanded retropharyngeal space, and you can see how that's intruding on these lumens here. So, and there's no thumb sign, so this is very obviously retropharyngeal abscess and not epiglottitis. Here's another one. You can see an air fluid level here. So these are severe cases, but I imagine on the USMLE they're not going to give you anything too subtle. Should be pretty obvious. And then this one, this is a little bit more subtle, but again, you can see that you don't have any parallel, this lucent space corresponding with the retropharyngeal abscess is not parallel to the vertebral bones. And again, here's your epiglottis, and it looks totally normal. So this is retropharyngeal abscess. Okay, so here is a CT, and I don't know exactly what level we're on here. This is sort of mandible area. Sorry, my phone's going off. So what you want to look for here is the space in between the vertebra and the pharynx. So this is not a very wide area. It kind of makes like a butterfly shape. This is obviously an abscess. You have this abscess here, and this is displacing the pharynx anteriorly, and this is why you get that bulge, that anterior bulge of the posterior wall. And you can also see here how this infection is very close to the vertebra, and you can get infection then into the bone. All right, so now we'll move on to lateral pharyngeal abscess. This is most commonly seen in children and adolescents, but because this does not necessarily involve those retropharyngeal nodes, which involute at age 5, you can get this in older children and possibly even adults. It is also associated with a recent history of ENT infection and can also spread from a retropharyngeal abscess. The symptoms include fever, swelling, sore throat, adenophagia, tender cervical lymphadenopathy, dehydration, or respiratory distress in severe cases. Very similar to what we see in the retropharyngeal abscess. There are two spaces that ENT surgeons like to divide these into, and they do, they're the anterior and posterior part of the lateral pharyngeal space, and they do have some symptoms that are unique to them, in addition to these symptoms that are common. So with an anterior space abscess, which is sort of the anterior part of your lateral pharyngeal space, you can get trismus, which is a difficulty opening the mouth, a swelling and induration along the angle of the mandible, and a medial bulging of the tonsil and lateral pharyngeal wall. And that can look like a lot like a peritonsillar abscess. But when you do the CT, you'll see that it's a lateral pharyngeal abscess. A posterior space abscess, the swelling is going to be more prominent along the neck and to the level of the hyoid bone. And because this is an anterior around the jaw area, the trismus is going to be minimal. For diagnosis, you can start with a soft tissue cervical plain film, but in many cases this is not going to help you very much because we can't visualize this space very well, not as well as we can on the retropharyngeal space. So in most cases, you're just going to need a CT with contrast, and that will be diagnostic. You need to do that, and it also can help you differentiate it from the retropharyngeal abscess. Management is virtually identical to retropharyngeal abscess. You'll ensure a secure airway, keeping in mind that it would probably be best to avoid direct laryngoscopy if you can. IV fluids for dehydration, routine labs, IV antibiotics. We take the exact same approach to all of these abscesses, all of these oropharyngeal abscesses, as far as antibiotics. We want to cover staph and strep and anaerobics. And then you'll get a pediatric ENT consult. Compared to the retropharyngeal abscess, the lateral pharyngeal abscess will more often need surgery. So surgery is usually needed except for the very, very small abscesses, and it'll be the surgeon who decides whether or not you need to do that. Identifying the anterior from the posterior lateral pharyngeal abscesses is very useful for the surgeon because it will help them determine where they need to make the incision. Complications here include carotid sheath erosion. Remember that the carotid sheath is part of your border of your lateral pharyngeal space, and so any of these abscesses can come dangerously close to that carotid sheath. So here's an example of a child with a posterior lateral pharyngeal abscess. So you note that he's got swelling all the way down to the level of the hyoid bone, which would be about right here. Here's your lateral pharyngeal abscess. This is probably anterior. Don't worry, you don't need to differentiate anterior from posterior on your exam. But lateral pharyngeal, obviously, because retropharyngeal would be right here. And then you can see here your internal jugular vein and your internal carotid artery. That's right here. And so you can see how it's very, very, very close to that area. Here again, there is some interference here, but you can again see the abscess. And note right here, I believe this is roughly where the jugular vein is anastomosing. Okay, so here is a sagittal view. You have your abscess right here. This doesn't really help us a whole lot because we can't see if this is how far this goes, if it goes laterally or if this is just restricted to the retropharyngeal space. So probably not the most useful pictures here. And then here's another one. So you have your abscess right here. Okay, it'd be easier to demonstrate this if I could scroll through all the slices, but alas, PowerPoint has not allowed me to do that yet. All right, the last one here is peritonsillar cellulitis and abscess. It starts as cellulitis, generally from there it goes on to abscess. This is also known as quinsy. That's sort of the old-fashioned name for it. Most common neck infection in children. There's an increased incidence in adolescents and then in adults aged 20 to 40. So this is something you can see in a variety of patients, not just kids. It is caused by bacterial invasion through the tonsillar capsule, which then leads to cellulitis and subsequently abscess formation in the surrounding tissue. Usually there's a recent history of acute pharyngitis or tonsillitis, and the symptoms include a sore throat, which often is referred to the ipsilateral ear, and then fever, trismus, dysphagia, halitosis, because this is occurring in the mouth area, and then muffled voice and dehydration. On physical exam, you will see an asymmetric tonsillar bulge, and it will displace the uvula. But sometimes this can be difficult, especially if you're examining a little kid. They won't want to open their mouth because trismus is commonly seen here. So for diagnosis, you'll get a CT with contrast. X-ray is going to be pretty much useless here. There are other ways you can look for this, but really CT with contrast is going to be your go-to unless you're trained in intraoral sonography. This is becoming increasingly used. It's very useful because this can actually help you differentiate cellulitis from abscess, and of course you're avoiding ionizing radiation. The management is going to be to, of course, ensure a secure airway, provide IV fluids for any child or adult that is dehydrated. You'll get your routine labs. You'll do IV antibiotics. We're doing the same coverage here as we did for the other two. And then ENT consult. The approach generally is for teens and adults. You'll do a needle drainage. And then if there's no improvement with IV antibiotics after 24 hours, then you do a tonsillectomy. For children, because they're just smaller, we'll generally just go straight to a tonsillectomy. Complications include rupture, which can then lead to aspiration pneumonitis, and then 10% of these patients will have a recurrence of the peritonsillar abscess. Now, of course, if you do a tonsillectomy, you won't get recurrence. So this is an example of a peritonsillar abscess on the left here. It's displacing the uvula. The uvula should be roughly corresponding to this little depression in the tongue, and this is deviated. Okay, so again here you see deviation of the uvula. Here's a CT. You can see the abscess here. Here's another one. You just see this deviation pattern. Okay, let's see. We've got another one. So again, you see deviation of the pharynx laterally, and then see, they didn't put any error. I think this is the abscess right here. I don't really see it up here. Okay, so this is a bilateral peritonsillar abscess. This patient was very unfortunate. So you can see there's, in this case, you're not going to have uvular deviation necessarily because you've got pressure coming from both sides. So there's really no deviation here of the pharynx, but what you do see are abscesses on both sides. Some notes. Okay, so we already sort of referred to this, but provided that you are empirically covering the patient for staph, strep, and anaerobes, a variety of antibiotic regimens can be used. So one source recommends amoxicillin clavulanate plus metronidazole. That's fine. You've got a beta-lactam plus a beta-lactamase, penicillin plus beta-lactamase inhibitor, and then you also are covering for anaerobes with metronidazole. So that's fine. Another source recommends a third-generation cephalosporin plus metronidazole or clindamycin. That's fine too. So that sort of goes along with what we were recommending in the lecture. But this says that you can also use a penicillin beta-lactamase inhibitor, probably in substitution for the cephalosporin. Another source recommends the following. You can use penicillin plus oxacillin okay, so this can be confusing. So penicillin plus one of these two, oxacillin or second or third generation cephalosporin plus clindamycin to cover the anaerobes. Or you can use a penicillinase-resistant penicillin plus clindamycin or metronidazole. Or you can use a third generation cephalosporin plus clindamycin and plus or minus nafcillin in addition. Don't memorize all these. Just remember to use something that covers staph and strep, so something like amoxicillin clavulanate or a third generation cephalosporin, plus something to cover anaerobes like metronidazole or clindamycin or vancomycin. We also recommend switching clindamycin to vancomycin in patients with severe disease or those who don't respond to clindamycin. And the reason for this is, in this case, we probably will be considering MRSA. And vancomycin has a nice dual effect in which it covers both anaerobes and MRSA. Immunodeficient patients, you should consider a non-tuberculous mycobacterial infection. Okay. Any immunodeficient patient with an infectious disease should be promptly referred to an ID specialist. However, you should keep in mind that things such as the MAC complex, they can cause something similar to this. And if there's significant deterioration, and by this I mean things that look like toxemia, such as chills, high fever, shock, that comes suddenly, you should work up for Lemierre syndrome because this can be a compromise of the veins here. Okay, so what is Lemierre syndrome? It's septic thrombophlebitis of the internal jugular vein because of encroachment into the carotid sheath. Usually what will happen here is it will send emboli to the lungs, and it can also send septic emboli elsewhere, like the liver, bone, and joints. But that's only going to happen if there's a PFO present. Remember, a lot of people have little PFOs that aren't symptomatic, so you should really have an index of suspicion for anybody, regardless of whether they actually have a diagnosed PFO. What would happen there, of course, is that you're going back from the internal jugular vein, back down to the vena cava, into the right atrium, and you get pushed into the left. Okay, so in addition to those symptoms caused by neck abscesses, these patients may also complain of GI complaints as well as pleuritic chest pain, and they can demonstrate hypoxia, probably because they're not breathing enough from the pain. For diagnosis, best first step is going to be a Doppler sonography of the internal jugular vein. If you have these symptoms and then you do your Doppler on the internal jugular vein and you note that there is thrombosis, pretty much have a diagnosis of Lemierre syndrome. But to secure your diagnosis, the most accurate, and I never really like to use most accurate for CT because you can always do an MRI, but the best step to nail down the diagnosis that you're going to do after Doppler sonography is going to be a cervical and chest CT with contrast. And what you'll look for is an internal jugular vein that is enlarged and does not enhance, and that suggests an embolism. In chest, you can see multiple pulmonary emboli, as well as empyemas and cavitations. Your management is really not going to differ a whole lot, other than you're going to keep a better eye on them. So you'll get labs, and that's going to include liver function tests, because we're always concerned about emboli to the liver. You'll get a PT and INR, and then you'll also get blood cultures. You'll continue IV antibiotic treatment. You'll need a longer course. These patients will probably need to be in the hospital for up to a month, and then immediate ENT surgery if you haven't done so already, and then monitor their SED rate for response to the antibiotics and a subsequent improvement in the inflammation. So here's an example of Lemierre syndrome as detected by Doppler. So this is just a regular old sonography. It can be difficult to miss these little emboli, these thrombi, but here you can see it's very clearly thrombus moving through here. So, all right. So there's the yellow. I was going to ask you to identify the problem, but here it is. So you don't see a whole lot of enlargement of the internal jugular vein, but what you do see is a filling defect, and that is consistent with Lemierre syndrome. So here's your carotid artery, which is bifurcated into internal and external. And it looks like the vein is just beginning to bifurcate here. So here you have internal and external. Here it looks like it hasn't quite bifurcated yet, or is in the process of bifurcating. This is a really bad one. You can't see a whole lot of other things, but this is sort of your general pattern of how these look. They just look like ring contrast lesions, but they're not. They're not ring enhancing lesions. They are veins. So you'll see your jugular vein, your internal jugular vein, with this basically contrast deficit. Here's another good one. This one's really good here. So here you have your internal carotid artery and your internal jugular vein, and you can see here that there is a filling defect. Okay, and finally this one. This is unique. So here you have your internal jugular vein, but you also have something. See if you can figure out what it is. Okay, so look for your abscess. Abscess is right here. You see some air bubbles. Okay, and then also sort of a lateral deviation of the airspace. And then you see this fistulization here. So look at this fistulization between the abscess and the internal jugular vein. So this is very clearly, this is another way that you can get, other than just direct invasion, you can also get this fistulization. And there's thrombus here. So note the filling defect compared to the normal jugular vein here on the left. Okay, that's all I got for you.